टाइटल के भयो एडिट मेडजेस्टी मेडिको लाइभ स्ट्रिम कहाँ हो त टाइटल यहाँ देख्ने हामी लाइभ स्ट्रिममा गइसक्यौँ है त्यही तर मैले अरे यहाँ पनि मैले गो लाइभ खाँदै थिएँ रेस्पिरेटरी फिजियोलोजी एक सेकेन्ड हामी लाइभमा छौँ है हामीले जे बोल्यो नि हाम्रो आइसक्यो युट्युबमा हेरेर हाम्रो मेजेस्टी मेडिको छ भनेर आइसक्यो ल अब युट्युबमा हेरौँ मेजेस्टी मेडिकोस लाइभ अर्कोचोटिबाट उस गर्नुपर्छ है फिजियोलोजी स्टेप 1 टेस्ट सिस्टम है अब हामी नेक्स्ट स्ट्रिमबाट चाहिँ ओके सो यो एभ्रिथिङ पर्फेक्ट छ ओके यसलाई अब फुल स्क्रिन गरेर तिमीले पढाऊ यो हामीलाई यहाँ पऱ्यो फुल स्क्रिन देन हामी यो गर्छौँ यसलाई अब F5 गरिदिउँ है त यो आइगयो होइन अरे यार हाम्रो अनुहार आइगयो नि त्यो इम्पोर्टेन्ट छ फुल स्क्रिन गर्दाखेरि हाम्रो अनुहार आउँछ कि होइन हात हल्लाउनु पर्यो हात हल्लाएको आयो भने चाहिँ यो क्याप्चर भयो फुल स्क्रिन के सानो स्क्रिनमा भयो आयो त आयो तर होइन यो स्क्रिन क्याप्चर भयो होइन कि प्रेजेन्टेसन क्याप्चर गर्नुपर्छ प्रेजेन्टेसन भयो यसलाई अब ओके मैले बुझेँ क्रिएट न्यू प्रेजेन्टेसन हुन्छ डाइरेक्ट यसमा जाने होइन होला यसलाई हामी लाइभमा गएपछि बल्ल click new के हुन्छ हेलो 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 नेटबाट हेर्छु है एक सेकेन्ड OBS स्टुडियो रेकर्ड होइन
जैसे यहाँ पर आप कर दे, अगर आप चाहे तो रीनेम भी कर सकते हैं, कोई दूसरा नाम भी दे सकते हैं। ओके करें। ओके करने के बाद आपको ये जो विंडोज है इसमें आपको सेलेक्ट करना होगा पावर पॉइंट। जैसे सेलेक्ट करेंगे ओके करेंगे, इसे ओके कर देना है। तो जब आप पावर पॉइंट में पढ़ेंगे तो ऐसा कुछ आपका पूरा दिखेगा। जब OBS रिकॉर्ड करेगा वीडियो तो ऐसा पूरा दिखेगा। और हम चाहते हैं ये ऊपर वाला पोर्शन ना दिखे, ये ड्रैग एंड प्लस के आइकन पर क्लिक करना है और आपको ऑडियो इनपुट कैप्चर लेना है। इसलिए आइकन में एडजस्ट करना होगा। अब ये मेरा एडजस्ट हो चुका है। पर आने के बाद फिल्टर्स पर क्लिक करना है और चाहते हैं मेरा एक छोटा सा वीडियो भी दिखे। इसके लिए आपको जाना होगा वीडियो के
हेलो रोशक सुन न त्यो हामी अनएक्रिमी जस्तो OBSमा जान थाल्यो प्रेजेन्टेसन जाँदाखेरि वेबक्यामै आएन कि हामी लाइभ जान थाले पेन ट्याबबाट आजबाट हामी लाइभ स्ट्रिम तिमीलाई लिङ्क अब पेन ट्याबलेबाट के हुन्छ पढाउन अनि विन्डो क्याप्चर गरे प्रेजेन्टेसन फुल स्क्रिन गर्दाखेरि चाहिँ फुल स्क्रिन देखाउँदैन के पावर पोइन्टको मा चाहिँ देखायो सबै ए ल ल ल हुन्छ 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 ल म आफै यहाँ जुगाड गर्छु यारमा रहेछ पहै यो खोल्नु OBS खुलिया छैन क्या तल देखाएको छैन OBS खुल्यो भने चाहिँ अबे यार तर ह्याङ भइरहेछ किन हो आयो जस्तो लाग्थ्यो अघि भर्खर कति बेला फ्रेस हुन्छ अनि अब सब हुन्छ पावर पोइन्ट सिलेक्ट विन्डो क्याप्चर पावर पोइन्ट क्रस भोल्युम presentation.ppx minimize हो लिसन गऱ्यो भने त फेरि हराइहाल्यो फेस क्याम पनि माथि नै छ माथि गर्ने काम भएन आज बिना अनुहारले पढाइदिने हो मट्टी उसो गर्नु थाल्यो यो एकचोटि युजै गर्नुपर्छ फेरि ढिलो हुन्छ होइन एकचोटि मैले हेर्छु फुल स्क्रिन गर्न मिल्छ किनभने सोनालीहरूले नि उसहरू यताउति गरेर फुल स्क्रिन त गर्छ किन यस्तो नुब भयो त स्टार पर्छ क्यामेरा पनि के हो होइन होला जे बोला बोला ल F5 केबाट पढाउन चाहन्छु ब्ल्याक ब्लू जुन भने अबे यार केबाट पढाउन चाहन्छु ब्ल्याक ब्लू यही देखाइरहेन to capture presentation oh yes नयाँ स्ट्रिम गर्नुपर्छ ल पखै ओह मैले बुझेँ ल यो काम गर्छ यो चाहिँ काम गर्छ 100% है तुक्का यसलाई हाइड गरिदिउँ 100% काम गर्छ होला यो त थाहा थियो त मलाई यार कहाँ गयो मेरो ध्यान डेस्कटप क्याप्चर गर्नुपर्छ नि त मैले कहाँ के गर्दै यार डिस्प्ले क्याप्चर गर्नुपर्छ नि बल्ल पो हुन्छ अब चाहिँ हुन्छ जस्तो मलाई लाग्छ हैन यो डिस्प्ले क्याप्चर ओके हो बल्ल पो आउँछ नि कस्तो नु भयो भने एकछिन 1 महिना नचला अब आयो यस्तो आउँछ नि त सुरुमा किनभने उनीहरूले डिस्प्ले क्याप्चर गर्ने हो कि मैले कस्तो मिस्टेक हो अब फेस क्यामलाई माथि राख्यो हो अब बल्ल हो कि बल्ल सिफ्ट F5 गर्यो Medicos गर्यो आयो तिमी यता अलिकति उसमा आयो है म अलिकति ठुलो बनाउनु पर्यो सानो आउँदो रहेछ कि तिम्रो क्यामेरा अलिक ठुलो बनाउनु पर्यो होइन म भन्छु तिमीले कहाँसम्म यता अलिकति ठुलो साइज तिमी यता अलिकति उसमा आयो है म अलिकति ठुलो बनाउनु पर्यो सानो आउँदो रहेछ कि तिम्रो यति त चाहिँ अलिक ठुलो बनाउनु पर्यो ओके म भन्छु बस क्लिक गर छोरा म इयरफोनमा के इन्स्ट्रक्सन ठिक छ तर ब्ल्याकमा उस गर यार तिमी यो हराइँदो रहेछ जस्तो लाग्यो ब्ल्याकमा हो ब्ल्याक सिङ गर्यो अब व्हाइट र राइट क्लिक गर तिमीले पेन्सिल गर राइट क्लिक पेनले खै राइट क्लिक गर त पेनले नजिक राख राइट क्लिक गर तिमीले होइन पेन माथि हुनुपर्छ कि राइट क्लिक गर्दा यहाँ हुनुपर्छ के भन्नु हटाउँदै एकचोटि इरेजर आयो होइन ब्ल्याक आयो अब यो नभए तिमी अलिकति कन्फ्युज भयो नि पेन माथि राख यहाँबाट राइट क्लिक गरेर हुन्छ कि बल पोइन्ट पेन भएन हेर तिमी यति स्क्रिन युज गर्नु पाएन है तिमीले यति गर्नु पाए तिमीले के हो व्हाइट आयो होइन लेख त ब्ल्याक आयो ब्ल्याक आयो होइन आयो ल एकचोटि हटाउँदै माथि पोइन्टर अप्सन कलर ल तिमीले अब सुरु गर्दा हुन्छ इरेज गरिदेऊ ब्ल्याक गरिदेऊ भएन सुरुवात बिफोर ब्ल्याक तिम्रो पोइन्टर फेरि हरायो बल पोइन्ट पेन मजाले लेखाउ न ओ गड म लिङ्क सेयर गरिदिन्छु है त बनाउन सुरु गर अब
Huh?
तिमीले यस्तो गरे हुन्छ तिमीले खासरी गर्ने के हो भन्दाखेरि त्यो मोबाइल छेउमा राख्ने हो होइन तिमीले कस्तो देखिरहेछ त भनेर तिमीलाई सजिलो हुन्छ कि
कस्तो देखिरहेको छ मतलब यता अगाडि
होइन तिम्रो युट्युब लाइभको स्ट्रिम कस्तो
ए
देखिरहेको
मैले देख्न पाउँछु नि त
अझ तिमीले देख्न पाएन नि त आफूलाई त्यही भएर सुरु गरे हुन्छ
सुरुमै So today we are going to learn about respiratory physiology. So we will cover the topic from various books. I have included the Kaplan, Fawcett, and Gyanam plus Gaitan. I hope this will be useful for everyone. So let us start our respiratory physiology with the pulmonary function test. So pulmonary function test is a index which is very important in our clinical day-to-day practice as well. So to study about the pulmonary function test, we should know, first of all, we should know about some of the volumes and the capacities. So I will just describe you some of the volumes and the capacities initially. So let us start that suppose this is the point at which our normal physiology is going on, that is our functional residual capacity is in, and then we take a breath in, then out, that is a tidal volume. So that is the air we inspire normally and expire. So inspire and expire, so this is a tidal volume. So in our volume pulmonary function test, we have volumes, we have capacities. So capacities basically means the addition of one or two volumes. Addition of one or two volumes, that is called the capacity. So this is a tidal volume which we normally inspire and expire. Then after the normal inspiration, if we take more breath in, that is called the, so this is called the inspiratory reserve volume. So this is called inspiratory reserve volume, the volume which we take after a normal inspiration. So adding these two volumes, that is inspiratory reserve volume and the tidal volume, we have the inspiratory capacity. So this is basically our inspiratory capacity. So if we take, this is the maximum amount of air we can breathe in. This is the highest level at which we can take the breath. Then let us study about the expiratory loops also. So we took the air in, we exhale it, and then we will use some of our expiratory muscles to do the forced expiration, and that will lead to the loop going downward. So this is called the expiratory reserve volume. So expiratory reserve volume. So this basically expiratory reserve volume and the tidal volume, that is basically called the expiratory capacity again. So there is some amount of the air which we cannot exhale out of our lung, that is called the residual volume. And adding the residual volume with the expiratory reserve volume, we have the functional residual capacity. This is the level at which our normal respiration is going on in our day-to-day life. This is the functional residual capacity. So we have the volumes. The volumes are tidal volume, inspiratory reserve volume, expiratory reserve volume, and the residual volume. So capacities, up to now we have dealt with inspiratory capacity, expiratory capacity. Now I would like to add one more capacity to this volume loop. Suppose we take some air in, then we took more of the air in to our maximum level, then we exhale the air up to our maximum level, up to this level. So this is called the vital capacity. This is called the vital capacity. So vital capacity is basically our inspired reserve volume plus tidal volume plus expired reserve volume. This is the amount of air which we can take in and out with our maximum effort. And this volume which we cannot take out, that is called the residual volume. So if we add the vital capacity with the residual volume, it is basically the total lung capacity. So from here to here, this is called the total lung capacity. Total lung capacity. Okay. So these are the volumes and the capacities we have to deal with in our pulmonary function test. First of all, I just wanted to just introduce you to these volumes and capacities initially, so that it will be much more easier in the further lectures. So now we will do is we will now study why we have all these volumes and capacity, and what basically means what is basically a functional residual capacity, as I have just mentioned it about it. So brother, F5. So now let us study about what basically our respiratory system looks like. Basically, in our normal physiology, when we have in our day-to-day life, our lungs are the elastic tissues, so they always tend to uh, have some elastic recoil. Due to this elastic recoil force, they always tend to collapse, and this is our chest wall. So chest wall always tend to spring out. So we have the two opposite forces, that is, one is the elastic recoil of the lung and other is the outward recoil of the chest wall. So when these two systems are basically attached to as these two systems are attached to each other via the palatal pleura, because palatal pleura attaches to our chest wall. So this is our chest wall, so palatal pleura attaches to our chest wall. So these two forces acting in the opposite direction creates an interpleural pressure which is negative. So this is a negative interpleural pressure in our pleura. So in our pleura, we basically have the negative interpleural pressure. So basically, if we this state at which the spring in the respiratory system, the chest wall want to go out, and the elastic recoil of the lungs prevent the chest wall to go spring out, and it further tries to collapse. But the lungs try to collapse, but it cannot collapse fully. This state of equilibrium is what we call the functional residual capacity. So this is the functional residual capacity. This is equilibrium state. This is not a resting state. Our respiratory system is not at a resting state. It is at the equilibrium state. We call it the equilibrium state, and this equilibrium state is called the functional residual capacity. So, so let us study about what are the factors. What are the factors that basically are involved in the factors involved in maintenance of functional residual capacity. So, what are the factors which tends to which tend to collapse the lungs? So, and what are the factors which tends to prevent the collapse of the lungs? So, what are the factors which tend to collapse the lungs? So, collapse the lungs. So first factor which tends to collapse our lung is our lung elasticity or elastic recoil of the lung. We call it elasticity or elastic recoil of the lung. Uh, Basically, elastic recoil or elasticity is dependent upon the amount of substance. Like in steel, what we call in steel, there is more elasticity, but there is less compliant. Compliant means basically if you, it's like when we friend also goes to have a tea and we call it that the friend isn't compliant. It basically means that he isn't so much flexible to do something, and that is the same meaning what we imply when we imply we talk about the compliance in the lungs also. So if we have what is the function of lung? The function of the lung is to expand. So the compliant of the lungs basically means if we blow the air, then it should expand. So if the lungs expand, then that is called the compliant. So that is basically what compliant is. That is the delta V by delta P. What our guidance writes. Delta V by delta P means that in 1 unit of pressure, if we give 1 unit of pressure, then how much volume of the lungs expand? How much volume of the lung expands? That basically is our compliance. So if we give the same amount of pressure and if the volume expands much more, then we say the lung is more compliant. And if the volume doesn't expand much, then we say the lung is less compliant. Okay. So first factor which determine our the factor which tends to collapse the lung, that is the lung elasticity or the elastic recoil of the lung or the lung compliant, and the lung compliant is basically, so we can write that the elasticity is inversely proportional to the lung compliant. Okay, so more the lung that means if there is more elasticity, then the compliance of the lung is less. That basically means the same thing. So after this we will just go into detail about this compliant first, and we will just discuss other factors also. So now let us study about little about the compliance. Okay. I don't know why the laptop is on. So let us study something more about the compliance. That is the very important topic, compliance. As I have explained that the compliance is basically inverse of elasticity. Okay, elasticity. So I have also mentioned that the mainly compliant depends upon the compliant elasticity depends upon the amount of substance. So more the substance, like in the steel, there is packed substance, so it doesn't allow anything to, when we exert the pressure, it doesn't allow to uh, expand. So that means that it has less compliance and more of the elasticity. So if we apply the same principle on our lungs also, our lungs are also compliant, and in our lungs also there are some tissues. Okay, there are some tissues. This is our lung, and normally our lung have various septa, various elastin. We have collagen and elastin in our lung. Collagen and elastin in our lung. Okay, so when these collagen and elastin are destroyed, suppose these collagen and elastin are destroyed, like in case of, we have one disease that is named as emphysema, where elastase, protein elastases, neutrophil elastases, these elastases are from the smoking and from neutrophils, all these. The elastases that will destroy our elastin fibers, so that will basically reduce our elastic substance. So that will elastic substance decreases, that means elasticity decreases, that means compliance increases. So basically from this we knew that in case of emphysema, the compliance increases. Suppose this collagen, elastic tissue and other substances are increased, suppose, like in case of fibrosis, like in case of sarcoidosis, amyloidosis, anything infiltration of the lung, like these lungs is infiltrated by some of these tissues. Then what happens is basically elasticity increases, and that's why the compliance decreases. So that what happens in all the restrictive diseases, that the compliance decreases. Okay. We have another one concept of compliance. Suppose this is a compliant curve. Okay, pressure volume curve. Okay, this is pressure and volume. Okay. Suppose this is a normal compliant curve. Normal compliant curve means at certain pressure, the volume increases. Okay, that means this is just delta V by delta P. Okay, so this is normal curve. But suppose there is one ideal one curve. So this basically what it means is that at lesser pressure also the volume is the same. Lesser pressure also the volume 18 is the same. That means this curve is more compliant. This curve is more compliant. So this is a curve of all these emphysema and all these obstructive lung diseases. We'll deal with them obstructive lung diseases. Difference in the after this topic. These are the emphysema. So this is the emphysema curve or the compliance curve. Compliant curve is increased. But if I drew one curve below it, then this is a restrictive curve. So all these restrictive diseases, suppose in the same pressure, after applying the same pressure also volume does not increase as much as this normal curve. So this is basically our restrictive curve. So this is very important curve, one important curve. Second thing I want to imply about the compliance of the anything of basically of our lungs is that if we look at this curve, okay, if we look at this curve, normal curve, then we can see that when we initially increase our pressure from here to here, then basically the volume also increases. But when we increase the pressure to here, the volume doesn't increase much. There is a flattening of the curve. It basically means that the more the compliance, when is our compliance of lung maximum? That means when we give a little pressure so it can expand much. The compliance of the lungs is much and very much high at functional residual capacity. So I have basically explained this is the functional residual capacity. Like this is the curve. Functional residual capacity is a point. This is the FRC, functional residual capacity. We have two curves. One is this is a meeting point of our of chest wall and the lungs. Okay, so this is functional residual capacity. Functional residual capacity is the state at which there is the maximum compliance. Okay, so if we are in functional residual capacity, then the compliance is basically high. But as we go higher away from this functional residual capacity, like as we reach away from this functional residual capacity, then the compliance decreases. That means if we expand our lungs much, initially this is a lung in functional residual capacity. Suppose I expanded this lung to this level, then the compliance decreases. Compliance isn't as much as in this state. What this curve explains. Okay, functional residual capacity. So after talking about this compliance about much, Now I would like to talk about this compliance third concept about the compliance. Okay, uh, compliance. Okay, okay. यता छ फोटो यता third concept I would like to impose about the compliance is about the obstructive and restrictive lung diseases. Okay, for this, as I have already explained some of the initial things about the volumes and capacities. Basically, I explained this for a purpose because we do one test, that is FEV1 by FVC. Okay, FEV1 by FVC. That is okay. That is suppose. Okay, suppose this is the state. Okay, this is the state of maximum inspiration. Okay, this is the state of maximum inspiration. We are in this state when I have inspired much of my air. So when I will inspire the air, okay, from initially I will I will inspire the air. This is the inspired loop. Now, as I have inspired the maximum here, sorry, this is the maximum inspiration. Sorry, this is the minimum inspiration. I started from here, okay, started from here, and then as I inspire, then this is the inspired loop. Then when I would like to expire, then most of the year I expire goes in first second. Okay, goes in the first second. That means I expire much of the year I have taken in my first second. So that is what the concept of FEV1 by FVC basically means. FEV1 basically means the amount of air I have expired, there is a force expired air volume in the 1 second, 1 second. This FEV1 by FVC, okay, basically is about 70 to 80%. Okay, basically it should be about 70 to 80%. So what basically goes wrong in the what is the basic difference between the obstructive and the restrictive lung disease is that okay, what is the basic difference between the obstructive disease and restrictive disease? I would like to explain this. So, in case of obstructive disease, there is a main problem in the flow. That is FEV1 by FVC. What is the main problem? FEV1, that is flow. We cannot exhale the air first year. We cannot exhale the air in the first second. Why we cannot do this? I would like to explain about how our expiration basically happens. Okay. So expiration, in our case of expiration, when we exhale the air, okay, then two factors come into play. Expiration when we exhale. There is two factors. That is, one is the lung volume, and another is the airway. Okay, another is the airway. What is the basic connection between the lung volume and the airway is that when the lungs are large, lung volume is large, airway diameter is also large. Why? Because the resistance is low. When lung volumes are less, then the airway are basically low. Airway diameter is also low. Airway diameter is also small because the resistance is high. So when I have the bigger lung, that is when initially when my lungs are compliant, then the airway are also large, and the air can easily flow. But when I have exhaled, when I start to exhale, then the volume start to decrease, then the airway resistance also start to increase, and airway basically becomes small and small. This is because of the radial traction. One factor that normally happens is because of the radial traction, which our lungs. This is a long parenchyma, and this is the airway. So radial traction basically keeps the airway open, and this radial traction doesn't happen, and that's why the airway start to collapse. So basically, what I mean is in expiration, the airways are small. One factor is our radial traction. Okay. Second factor is our intrapleural pressure, because intrapleural pressure is the pressure of all our thorax. It is not the pressure. It is not only the pressure inside our pleura. It has effect on whole our thorax. So this will for the collapse the airways, because at the expiration, when we have expiration, the intrapleural pressure basically shifts towards the positive, and when there is a positive airway pressure outside the airway, then that basically collapses the airway. So in case of expiration, two factors are involved in the making this airway smaller. So most of our ear, as I have already explained, that much of the ear we exhale basically happens in the first second. But what happens in the obstructive disease? Suppose this will be the curve. Then obstructive disease, we have this sloping of the curve. Okay, the sloping of the curve. Because we cannot exhale much of the air, so this part of the curve is basically dependent upon the elastic recoil of the lung. Okay, because elastic recoil of the lung is what happens in the normal expiration, but as the elastic recoil of the lung is lacking in case of obstructive lung disease, so this curve is little slanted, because it can the elastic recoil of the lung cannot happen as much as this. Okay, so that is what basically happens in the obstructive lung disease. So obstructive lung disease is a obstruction in the airway, and that is a obstruction in the flow. But what is the main factor which happens in a restrictive lung disease? The volume. Okay. In restrictive disease also there can be a FEV1 reduction or flow reduction, but main, if I ask only one factor that is deficient in the restrictive lung disease, that is the flow or volume, that is functional vital capacity, that is FVC. Okay. So that is basically basic difference. So obstructive and restrictive. So if we just plot this, then we have FEV1 by FVC, FEV1 low, FVC low. That is the main difference. So we have FEV1 by FVC, that is low. So FEV1 by FVC can be normal or high also. So main difference is this. And if we remember this, then we can remember everything. Like in obstructive lung disease, like there is obstruction, so the air cannot go out. This basically there is the airway trapping. So there is the increase in residual volume. When there is a residual volume increase, there is an increase in functional residual capacity. Okay. Whereas in residual volume decreases, functional residual capacity decreases. Basically, restrictive diseases lungs shrinks. So what happens to this curve? Suppose we are in this expiratory. Okay, this was the normal curve. Suppose in restrictive disease, whole of this curve spirometry shifts downward. Okay, this is a restrictive pattern, and in obstructive pattern, basically whole of our curve shifts towards upper side. Okay. Because everything increases. like residual volume increases, functional residual capacity increases, everything increases. So the obstructive curve shifts towards upward and restrictive curve shifts towards downwards. Now we will talk about another important concept about how normal respiration happens when normal respiration. Normal respiration. Uh, as I have explained about the intrapleural pressure, why this intrapleural pressure is basically negative. Negative because the lungs tend to recoil inside and the chest wall tend to spring out. So that is the reason why there is the intrapleural pressure which is negative in our respiratory system. So suppose this is our lung and this is the intrapleural pressure which is negative. So what happens in our normal respiration? Suppose in the inspiration, we'll look at what happens in inspiration, how inspiration happens and how expiration happens. Okay. In our physiology, we consider the 760 mmHg, which is a normal atmospheric pressure, as 0 because it is easier to calculate. So we consider this as 0. So what happens is in our resting stage, when there is the normal resting stage, then this intrapleural pressure is basically -5. Okay, this intrapleural pressure is basically -5. Okay, this is basically -5. When this intrapleural pressure is basically -5, what happens is one concept we will have to read before this is a concept of transmural pressure. Okay, transmural pressure. Then we will understand everything. Mural like transmural ischemia. Transmural basically means wall. Okay, pressure in between the wall. That is a transmural pressure. Suppose this is a balloon. Okay, a balloon. And if I have more pressure inside than the outside, then this balloon will expand out. Okay. So let me consider one balloon. There is a pressure 1, there is a pressure 2. Okay. And if the P1 minus P2 is positive, that means the pressure inside is greater than pressure outside, then it will spin out. But if the pressure inside is less than pressure outside, then that will collapse. Okay. So that is basically, this is the basic concept in everything, transmural pressure. In the transmural pressure we call here is our transpulmonary pressure and transrespiratory pressure. Okay. Suppose this balloon which we were talking about is alveolar. If we have more pressure inside than the outside, then this alveoli will expand. Okay, this is called the transpulmonary pressure. Okay, this is called the transpulmonary pressure. So what happens when we are in the resting stage is that the intrapleural pressure is -5. Intrapleural pressure is -5. So this is a alveoli. Okay, this is alveoli, and it has a 0 pressure. That is, it communicates freely with the atmosphere. Okay. It has a 0 pressure when there is when the intrapleural pressure is -5. Then what we do during the inspiration, the muscles involved in inspiration mostly is the diaphragm. First, what we do is we take this dome of the diaphragm downwards. What basically it does is it increases our volume. Okay. Secondly, what we do is we take our rib cage upward. That is called the pump handle movement. Okay. This also basically what it does is it increases the volume of the chest wall. So according to the Boyle's law, pressure and volume is a constant. That is, pressure is in proportion to volume. So when the volume increases, just what? The pressure decreases. That is, this -5 now basically goes to -8. So intrapleural pressure was initially -5, now it goes to -8. Now when it goes to the -8, that means normally the transmural pressure initially in the alveoli was 0 minus -5, that was 5. But now it became 0 minus -8, that is 8. So now alveoli, now it will start to expand. But because of the negative pressure, it starts to expand. But when it starts to expand, but the volume increases. Okay, like the volume increases inside the alveoli also. When alveoli volume increases, alveoli pressure decreases. So normal pressure like this. Normal pressure happens like this in the alveoli. Like it is 0, 0, -1, 0, +1, like this. So initially the alveolar pressure was 0. Now when the transmural pressure increases, and it reaches to 8. Now this volume increases inside the alveoli, so pressure decreases, and thus the alveoli now become negative. So when the alveoli pressure inside the alveoli becomes -1, and the pressure outside in the atmosphere is 0, so now according to the pressure gradient, the air enters inside, and that is what we call the inspiration. So that is how the vesical inspiration happens. So this 0 will air flow will continue until this -1 will become will become 0. Okay, this -1 will become 0, and there will be the equilibrium state, and then the inspiration is hindered. Now what happens in the expiration? Expiration is basically a elastic recall. So whatever happens in the inspiration, that just goes back to this normal state. That is due to the elastic recall of the lung. So now what it happens is the -8, when in the expiration, the dome of the diaphragm goes backward, so the volume decreases, so the volume of the chest wall decreases. That means the pressure increases. That means the pressure increases. That means the intrapleural pressure it further increases. That means it becomes more positive than -8. It was -8. Now it again goes to -5, and the alveolar pressure now has equilibrium, and it will go from 0 to 1 because the transmural pressure has again decreased. So it will reach to +1, and when there is a +1 in the alveoli, and outside pressure is 0, then the air moves from inside the alveoli to the outside of the alveoli, and thus the expiration happens. So this is how the basically inspiration and expiration happens in a normal person. I don't know what has happened. Forgive. राम्रै गयो तपाईँ राम्रोसँग पढाउनु त्यो पछि गर्नुपर्छ यार टेस्ट नौ बजिसकेको छ भ्याउनु नि रहेछ त भ्याइदिउँ क्या यतिकै अरू कुरा पढाउनु क्या कम्प्लायन्स मात्रै छोडिदिउँ क्या के भयो So, so I have just explained about the normal inspiration and expiration. So, in normal inspiration, the muscle involved is the diaphragm. So, what are the muscles that can be involved in the forceful inspiration also? That is basically external intercostal muscle, external intercostal muscles. Okay. If we have to take more than this tidal volume, like we took it to Inspiratory Capacity, this more of Inspiratory Reservoir, then we use the forceful inspiration, and this is the external intercostal muscles, sternocleidomastoid, scalene muscles. Okay, these are the muscles which we use in our forceful inspiration. But in our normal inspiration, silent inspiration that we use, normal inspiration we use only the diaphragm. Whereas the expiration is a passive process. We should know this expiration is a passive process. It happens because of the elastic recoil of the lung, because our system basically goes back to the functional residual capacity. So, but if we have to take expression, forceful expression, so then what are the muscles involved in the forceful expression is our abdominal muscles. Okay. Abdominal muscles we use in case of the forceful expression. Now let us talk about, as I have explained about all these changes, then let me explain about the cardiovascular changes, little about the cardiovascular changes, because as I have talked about the intrapleural pressure, so I would just like to talk about some of the cardiovascular changes. Okay, this is negative pressure, intrapleural pressure. Negative intrapleural pressure will lead to the negative pressure in the thorax. Okay, so this negative pressure inside the thorax is not basically only for the alveoli, not basically only for the alveoli, not basically only for the airway. This is also for all the veins and arteries that exist in our thorax. So what basically happens, what is the consequence of this is like in inspiration, as I have explained, what happens in inspiration is that it goes from -5 to -8. Okay, it becomes more of a negative. That means, suppose this is a vein coming towards the heart, like superior vena cava or the inferior vena cava. Okay, these are the veins which are coming toward the right side of the heart. Okay. And what happens in the inspiration? What happens in the inspiration is that the -5 goes to -8. So that means the intrapleural pressure, the transmural pressure in the vein also increases. That means it was like 0 minus -5. It was like 5. It may not be 0, but it basically it reaches from 5 to 8. That means the pressure increases. That means the venous pressure also increases during the inspiration. So that means during the inspiration, what basically happens is these veins now start to feel the heart. Okay, that basically happens in the inspiration. Okay, when the heart is filled, then this heart is filled. Okay, but what happens is the pulmonary vasculature also is filled in inspiration. So there is a pooling of the blood in the pulmonary vasculature, but systemic vascular pressure decreases. So during inspiration, when the systemic vascular arterial pressure decreases, so basically during inspiration when the arterial pressure decreases because there is a pooling of the blood in the pulmonary circulation. So when there is a arterial pressure decreases, then it will inform the baroreceptor, vagal reflex, okay, and that will increase the heart rate. Okay, so that's why during inspiration sometimes there can be a reflex tachycardia. So basically why this is the reason. So why we do why we choose the different. We have to maintain the ECG parameter according to inspiration or expiration, because we normally tend to do at the end of the expiration. Okay, that is the reason for this. Okay, inspiration, the reflex increases, and that's why the heart rate also increases. So ECG changes can be different, and we should note about that too. And expiration, just opposite happens. Okay, these veins are now collapsed because the intraocular pressure is negative and the return there is no return towards the heart. Then the blood pressure increases. Then there can be bradycardia. During the expiration. Okay, there is not a bradycardia, but heart rate certainly decreases during the expiration. So that is the consequence of the intraocular pressure changes within the thorax. Now I will also like to talk about little about the ventilation and the dead space. Ventilation. Normally, what is the volume? Okay, suppose this is a tidal volume. This is the respiratory rate. Okay, tidal volume into respiratory rate, that is the amount of air in the lung. That is called the minute ventilation. This is called the minute ventilation. That means in 1 minute, what is the ventilation of the lung? But as we know from the Weber's model, what do you know about the Weber's model? We know from the Weber's model that the initial 17 branching is the conducting zone. From 18 to 23 is only the respiratory zone. Okay. So in conducting zone, there is basically no gas exchange. Whereas in the respiratory zone, there is only gas exchange. So this conducting zone is basically the anatomical dead space. Okay. Whereas this is the only reason where there is a ventilation. So if we exclude this tidal volume minus dead space into respiratory, that is basically the amount of air which reaches the alveoli and is available for the ventilation, and that is what we call the alveolar ventilation. Okay, so there is one concept about minute ventilation and another concept of the alveolar ventilation, and this is the amount of the air which is basically what is important for us. We have two components over here. One is tidal volume, one is the dead space. Okay, in normal person, okay, like in normal person, if there is no any derangement, then the dead space, total dead space, is equal to the anatomical dead space. Okay, anatomical dead space is the total dead space. But if there is some pathology, then we have another dead space, that is a physiological dead space. Physiological dead space basically means there is nothing anatomical wrong, but there is something defect in the physiology. That's why there cannot be the gas exchange. So that is a physiological dead space, and that is the total dead space. So whenever we try to increase the, suppose in case of any cases, like I have to increase this minute ventilation, like I have to increase the alveolar ventilation, then the best option is to increase the tidal volume, okay, than to increase the respiratory rate. So what we basically do is we increase the tidal volume. If we have to increase the alveolar ventilation, we increase the tidal volume, and that will increase the alveolar ventilation, and that will ventilate our lung more. So physiological dead space, we'll talk about this more in detail in the later in the another discussion. But this is a ventilation perfusion mismatch. Like in case of ventilation perfusion mismatch, that is a dead space, that is ventilation can be wasted perfusion can be overchecked, and that can lead to the physiological dead space, and that can lead to increase the dead space in the person, and that will lead to the decrease in the alveolar ventilation of that person. Okay. Now we will talk about. I think we will conclude this topic today with all these long mechanics and ventilations. We will talk more about the other topics like the partial pressure of gas and everything, and the diffusion and everything in the next chapter, next lesson, or next